I'm going to go over the difference between indirect antiglobulin testing and direct antiglobulin testing. It seems to be an area that a lot of students get confused in, so we're going to take a few minutes and talk about it. So, indirect antiglobulin testing, we are looking at what happens in vitro. We are putting the antigens and the antibodies into a tube to see if they react. Direct antiglobulin testing, we want to know what's happening in vivo. The antigens and the antibodies are reacting in the person's bloodstream, in their body. So when we pull that tube, in the actual tube we've drawn, the blood has already reacted. So we're going to talk about the indirect first. So the indirect, there's two major tests that we do that are considered indirect antiglobulin tests. The first one is our antigen typing. So this is what we look at when we have the patient's red cells, and we want to know what antigens they have on their red cells. We do this with things like, when we're looking at if a mother has an antibody, maybe you find out if dad has the antigen to find out what kind of reaction we could possibly be having. So we take the patient red cells and we add a known antibody, or antiserum. It comes in the little tubes. So I got the wash cell of the patient, and I'm going to add the known antiserum. And in this case, I'm using Duffy A. So I take my known anti-Duffy A, put it with my red cells, and I'm going to incubate it. After incubating, we're going to wash it 3 times, and we're going to blot it really well. Now remember, we always blot really, really well before adding the HG, because we get that saline that hangs around the lip of the tube, and if we don't pull that out, when we turn the tube over, our HG that we add to the end is going to get diluted out. And if we dilute it out, we may not have as strong of a reaction, or even may have a false negative reaction. So it's really important to blot that tube really, really well. So we incubate these two together to see if they become sensitized in vitro, inside the tube, at the HG. So this is kind of what's going on. If this is our patient red cell, if our patients have Duffy A and I add known Duffy A antiserum, let that incubate, blot it real well, and add my HG, I'm going to get agglutination, because that HG, remember, is going to bind to the FC portion of the antibody, and so it can reach multiple antibodies versus an IgG molecule that has those little tiny arms that can't grab multiple antigen sites. So that's what's going on. We are putting this antisera and this antigens together in a tube to see if they react. The other indirect antiglobulin test we do is antibody screens. We do antibody screens all the time, right? So we're used to seeing these. So what we do is we take the patient plasma, and the patient plasma, we want to know, do they have any antibodies? So in this situation, we take with our known cells. We have a cell, for example, this is cell number 1 from our screening cells, and we know what antigens are on it. So I'm going to put my patient plasma against that cell, and in this case, my patient has anti-little c. So if I take that patient plasma and my cell number 1 has little c, they're going to react. I'm going to incubate them. I'm putting the cell number 1 in a tube with the patient plasma, and we're going to incubate. Wash it 3 times, blot it really well, and then we're going to add the AHG. At that point, when we add the AHG, same as with our antigen typing, we're looking for agglutination to let us know that yes, there is an antibody that is attaching to the antigen on this cell. Now, when we are talking direct antiglobulin testing, we are looking at what's happening in vivo, in the body. So you can see here, in the body, we have these cells, and this is an example, for example, of donor cells, because my donor cells are blue, my patient cells are red. So I've got donor cells, and I've got antibodies attaching in the body to those cells. So we draw the blood out, and in the blood we have a mix of donor cells, patient cells, and the donor cells have antibodies coating them from in vivo. So then we're going to do the same thing, except we don't have to incubate them outside. We are literally going to wash that cell really well. We're going to blot it really, really well, and we're going to add HG, and you're going to look at it macroscopically and in a microscope. Follow your procedures wherever your facility says, because some do not use microscopic, they only look at macroscopic. So if they look microscopically, then under the microscope, we're going to look at it and we're going to look for agglutination, and they're going to be tiny little agglutinants in a big sea of cells, because you got to remember, we got all these red cells and only a few of them are donor cells, and because of that, we're not going to have like major agglutination in situations like this. So I hope this was able to help you a little bit differentiate between indirect, putting them in a tube and letting them react together, or direct, they already reacted in the body, so we only have to do the AHG step versus over here doing that first incubation before the AHG. If you have any questions, be sure to reach out.